Hi, my name is Dr. Salil Khandwala, and I am the Medical Director at Advanced Urogynecology of Michigan. Our practice is a subspecialty practice in gynecology that addresses issues of the female pelvic floor called female pelvic floor dysfunction, namely bladder conditions such as urinary incontinence, vaginal or uterine conditions such as prolapse and pelvic pain, and bowel conditions such as constipation or fecal incontinence. A lot of information can be found on our website, which is www.augm.org, as can be seen here. Today, we are talking about a very, very common condition that women experience, uterine prolapse. Also, we shall be discussing, does hysterectomy have a role in this? So the question then becomes, as seen on this slide, to save or not to save the uterus. How do we manage prolapse of the uterus? So let us, before that, discuss what is pelvic anatomy. So let me show you a pelvic model. I hope you can see this model. So this is the front part, this is the back part, this is the wing bones, and this is how the pelvis is looking from the side, and this is how the pelvis is looking from the front and looking from the top and the back. So let me show you therefore the inside part of the pelvis as you look from the top. Let's look at this particular slide to see that. So you can see that, remember the top, so this is the front, this is the back, these are those two wing bones I showed you, and these are the muscles. So the muscles form the floor of the pelvic bony cavity, and that's why it's called the pelvic floor muscles. On top of the muscles are these ligaments, and ligaments are strong connective tissue structures that hold organs in place. Mainly, let me draw your attention to these two ligaments, one on each side, called the uterosacral ligaments. Why are they called uterosacral ligaments? Because they go from the uterus, which is right here, to the tailbone, which is the sacrum, and they're attached to the sacrum. Therefore, the uterosacral ligaments. These are very, very important ligaments because they go up and hold the uterus in place and maintain the normal anatomy of the uterus. Along with this strong ligament are these two ligaments that go to the side. You can see this one here, and that's called the cardinal ligament or the transverse cervical ligament. And this ligament goes from the cervix and attaches to the side part of the bony pelvis, as can be seen here. So cardinal or the transverse cervical ligament. Again, these ligaments are important, as is the muscle, to keep the pelvic organs, especially in this case the uterus, in place. So this is how the normal anatomy is displayed in a woman when you look from the side in profile. This is the top, this is the bottom, this is the front, this is the back. You got the pubic bone in the front, the bladder is behind that, the urethra is the tube that brings the urine to the outside. Behind that is the vagina. On top of the vagina is the uterus, which is inside and on top, and then the rectum on the back. And then you have the buttocks behind that. So how does prolapse occur? So let me show you a simple animation. So let's consider this is a boat which is supported by its anchors or the moorings, and then you have the water which is keeping the boat afloat. So the water is like the strong pelvic muscles which are tonically, it means all the time contracted, the muscles that I just showed you, and those muscles keep the organs afloat or where they're supposed to be. On top of that, then you have the ligaments that keep the organs displayed on top of the muscles. So you really need both the muscle and the ligaments to do the job so that nothing falls down. However, if the water or the muscle starts weakening and the water level goes down, there is more strain on the ligaments and more strain on the ligaments as it goes down further. So up to some time, maybe a few years, the ligaments can hold on, but ultimately they crack. And when the ligaments break, the uterus falls down or the vagina falls down, and then you get prolapse. So that's a very simple mechanism to explain uterine or uterovaginal prolapse that could happen because of muscle weakness and ligament breakdown. So remember I told you this is the uterus right here. This is the cervix. These are the two tubes on each side and the ovaries. So when you look at it from the back, these are the two ligaments, the uterosacral ligaments that go back and those lateral ligaments that I mentioned. Strong ligaments that hold the uterus in place. You can see them the same in profile. The uterus is here. The bladder is here. The rectum is at the back. See how this ligament starts from the uterus and goes to the tailbone, the uterosacral ligament. And this is again, if you look from the top, like how I showed you, you have, remember, the muscles at the back. So these are the muscles below it. On top of the muscles are these ligaments, the lateral cervical ligament and the uterosacral ligaments that are holding this uterus in place and preventing it from falling down. And in a diagram, it can be shown, this is the bladder, this is the uterus. You can see the uterosacral ligaments at the back going to the tailbone and the transverse ligaments. So by now you figured out that it is important not only for the muscles to be strong, but also these ligaments to be strong to keep everything where it's supposed to be. However, if the muscles weaken, you can see how this muscle has fallen down. So the muscles weaken and the ligaments break, then starts the problem with prolapse. So why does it happen? Why do these muscles weaken and why do the ligaments break? Well, we all know the one most common thing is childbirth. You know, the baby is coming through, that can put strain on the muscles, can put strain on the ligaments, and that could be responsible for it. Then strenuous activities on an ongoing basis, not like once or twice, like coughing, especially with smokers, persistent and chronic coughing, chronically lifting heavy stuff, chronic constipation. Chronic, that means all the time. Weight, which is again chronic pressure on the abdominal structures. Menopausal changes because of lack of estrogen causes the connective tissue and the ligaments to also become a little weaker. And finally, what was the inheritance of the connective tissue? Some women inherit strong connective tissue from their parents, whereas some may not have. That is why it is not uncommon for prolapse to happen in family members, mother, daughter, and so on. So let's briefly go over some types of prolapse. Now this is again the uterus on the top, this is the vagina, the bladder in the front, the rectum at the back. So when you have a bladder prolapse, that means the front wall, this is the front wall, remember this is the front wall of the vagina. When it starts falling down, then you get the bladder which is coming down, and that's how a bladder prolapse looks. If it's the back wall of the vagina, and that's called the rectocele, or the rectum, which is the back wall here, is falling down, and that's called rectocele. Or if the small bowel is herniating from the top and back of the vagina, it's called a small bowel hernia. So that's called a rectocele or enterocele. But today what we're talking about is uterine prolapse. So when the uterus, which is on top, and it's coming down to the opening or outside, and you can see it, that's called uterine prolapse. This is a classic uterine prolapse where the uterus is outside of her body, so it essentially turned inside out. So what's the most common symptom? That she can feel it. There's a bulge that is sticking out or coming outside is the commonest symptom. If prolapse is left unattended, like the prolapse I just showed you, it can cause the bladder to back up and infections that could cause kidney damage, obstruction of the tubes coming from the kidneys, and cause again kidneys to swell up. Because it's all the time outside, the vagina can become dry, ulcerated from rubbing against the clothes and thighs, and that can cause irritation and bleeding. And if it's the back wall prolapse, it can also cause bowel issues. When we examine the patient, this is the most common examination done by gynecologists, right? I'm sure most women have had this position for pap smears, but again, prolapse doesn't happen lying down, and most women know this. So the key thing, what we do is we have them bend the leg up and strain down to see if there is prolapse coming down as we tilt the pelvis, but most importantly, have her stand up and strain. This is a 17th century French slide that shows the French surgeon examining a patient for prolapse as she's standing up. So this hasn't changed for centuries. Most important way to diagnose prolapse is standing up and straining down. Once we've diagnosed uterine prolapse, how do we manage this prolapse? Should we do a hysterectomy or should we not do a hysterectomy? Should we preserve the uterus? So let's see what the evidence says. Let's talk about hysterectomy. When the uterus is coming down, the most common operation done is called a vaginal hysterectomy. So this is the uterus right here. We've cut out all the ligaments and we're finally cutting out its blood supply, and then the uterus is delivered out and then the vagina is closed. So this is called a vaginal hysterectomy. Once the vagina is closed, it is then anchored to that ligament called the sacrospinous ligament, which comes from the sacrum and attaches it to the spine here. And you can see this vagina, it's gone and it's anchored back there so that it will not fall down. This is called a sacrospinous ligament suspension. Hysterectomy, on the other hand, which is uterine preservation, uses a mesh, which is a large macroporous, that means wide pores, so that the infection can be easily contained and taken care of by our defense cells called the macrophages. At the same time, it's a single filament of polypropylene called proline, which is wound into this netting. So what that does is it holds the uterus and it again reattaches to the ligaments that we talked about and supports the uterus, vagina, and the different organs by attaching it back to its core ligaments. So question is, all right, we talked about both hysterectomy and preserving the uterus, hysterectomy as it's called. So the question most patients ask me is, why not remove my uterus? I've finished having kids. I'm in my mid-60s. I'm postmenopausal. I do not need the uterus. It may become cancerous, who knows? And it's falling out. So it's falling out, just take it out. What sense does it make to leave it behind? Well, now let's see if it makes sense. So this is the uterine prolapse. And why does it happen? Now look at this. This is your backyard. So now backyard, the swing is broken because the chains have broken. And you call a repair guy and he says, hey, let's change this plank. So you'll tell him, what's that going to do? If we change the plank, it's not going to fix my problem. You got to fix the broken chains. There's nothing wrong with the plank. So here, the analogy is the plank is the uterus. There's nothing wrong with the uterus. It's broken and fallen down because the muscles are weakened and the ligaments are torn. So why don't you just recreate those ligaments and my uterus is back where it needs to be. There's no need to take it out. So let us see, well, both things make sense, right? Hysterectomy says, hey, it's falling out, take it out. And the other argument says, why take it out? Because the uterus is not the culprit. It's actually the victim of the prolapse. So don't hurt the victim. Take care of the problem. So let's see what the evidence is. Let's look at hysterectomy, taking the uterus out. 40%, almost half of women who undergo a hysterectomy present with prolapse of the vagina. That means after the uterus is removed, almost half of the women will have the vagina falling out. Hysterectomy increases the risk of bladder problems such as urinary leakage. It negatively impacts a woman's sexual and personal identity. A very famous gynecologist in England by the name of Dr. Shaw in 1933, way back 1933, stated, hysterectomy as a cure for prolapse is useless, and the very worst type of prolapse is the one that occurs after a hysterectomy. A recent study at Cleveland Clinic, which was done about a couple of years ago in 2017, showed that if women are offered a procedure with similar success, more women choose to keep their uterus rather than undergo a hysterectomy. Hysterectomy is associated with a higher risk of pain during intercourse, mainly at the top of the vagina. Why? See, when you take the uterus out, you have to close the vagina somewhere here. When you close it, you've lost a little bit of the vagina at the top and some depth. Then when you close it, this becomes a scar. Scar means fibrosis. Fibrosis meaning tough tissue. So during intercourse, when the penis hits that area, it can cause discomfort. What are the other? Then there are some basic risks of just doing a hysterectomy, which involves bleeding from the uterine vessels, infection because now you're getting into the belly cavity to take this uterus out. And then ultimately, besides the medical aspects, what about cost? The cost goes up because I charge more as a surgeon, the anesthesiologist charges more, the pathologist now has a specimen to review, and the hospital charges more. So everybody charges more. So guess what? We're all paying for the cost of doing a hysterectomy, which may turn out to be unnecessary. So let's see what we see further. How about preserving the uterus? Should we do it with mesh or without mesh? Without mesh is called native tissue, where we use the patient's own tissue. Native tissue hysterectomy, they found, like what I showed you, attaching the vagina to the sacrospinous ligament, they attached the uterus to the sacrospinous ligament. And what two studies, Lynn and also Dietz, they found that 75% of cases failed with stage 3 or stage 4 uterine prolapse. Now, these are the prolapses that we normally take care of. These are the prolapses where the woman can actually see the uterus sticking out of the vagina. And that is called stage 3. And if it's completely out, it's called stage 4. And 75% failure. So can you do without mesh? Nope. The answer is no. So what does a mesh do? So when this uterus is falling down because the ligaments have broken, uterus is not the fault. So what you do is you recreate those ligaments. And how do you do that? Is by attaching those mesh arms to the uterus and then back to the sidewalls. Let me show you another pelvis. As you can see here, this is the uterus. And now you can see that the uterus, which is in front, let me show you this way. This is the front, this is the back. Now, I hope you can see this, but this is the uterus, and these are the mesh arms that go from the uterus and attach to the tailbone ligaments. So that's how you support this. So there is no need to take this fellow out. Just leave him in, and it stays in. Keep it in. So what is the evidence? So we did a study of 77 subjects with a stage 3 or 4 prolapse. Remember, with native tissue repair, 75% failed. Our success was 91%, so only 9% failure. We are presently completing another study with the Restorel mesh and the hysterectomy. So in our practice, we have given up on doing hysterectomies. We say that, hey, you came with the uterus, you keep your uterus. I do not want a uterus, nor do you want to lose your uterus. Just hang on to it and hang in there. What are the advantages of hysterectomy? No need for opening the abdomen because this is done entirely from the vagina, something we have coined a term NINOS. No incision natural orifice surgery. That means there is no cutting on the outside. It is done right from the natural orifice, which is the vagina itself, where we do this operation. So done entirely from the vagina. You can't even see anything on the outside. It's done completely from inside the vagina. There's a high success with the mesh arms acting as the new ligaments. So hysterectomy, yes or no? What is the verdict? Nope. Save thy uterus. He's happy to be inside. Leave, let him be, and he'll do fine. Or she will do fine, however you want to say it. So bottom line is a hysterectomy is not required for management of uterine prolapse. Almost all cases can be done very well with supporting the uterus back inside. There is always some advantage of keeping the uterus in. You maintain the the vaginal length because now you've not chopped off the top of the vagina. Number 2, you have the cervix still, which produces some mucus that helps during intercourse. Third, the patient still feels that she has all her organs and she does not feel a void or emptiness in the pelvis, and that helps her sensation of well-being. And fourth is there is no reason to take it out. In fact, everything is against it being removed. Worst case scenario, let's say, God forbid, and the patient were to get cancer, we can still take the uterus out vaginally or laparoscopically. Just because she has had mesh hysterectomy does not mean that she cannot have a hysterectomy in the future.